Yes, Joseph.
Mm,
I think it's about time we start.
sure.
So others will join on the way.
Yeah.
So welcome everyone. It's another Sunday, and today we have another case. I'll be presenting this case, and Joseph will be discussing. And for those who are probably new to the platform, this is so the platform is called AfroDX. Uh, we started this thing, me and Joseph, and the sole purpose of this is to learn medicine. So what we do most times, maybe things will change in the future, but the main thing is one presents a case and the other one discusses a case, and this case is completely unknown to him. So, for example, today I'll be presenting a case to Joseph. Joseph doesn't know anything about the case. So, what we learn from him is how he approaches the case, the way he reasons through the case, and so all the way from the history, his interpretation of physical examination and different investigations, and how he finally arrives at a diagnosis. So what is most important to us is the journey, the path that he takes to arrive to the diagnosis. So it's not very important whether he gets the diagnosis right or not, but what we are most interested about is the journey on how he reasons through the case. Yeah, so today I have another case for Joseph, and welcome everyone. You can sit back, relax, and listen. And then at the end, after Joseph has finished discussing the case, at the end we'll have a session if someone has any comments, any questions, anything that they would like to share with us will be open at the end. So welcome everyone, and Joseph, whenever you are ready, let me know so we can start.
Yeah, sure we can.
Can you see my slides?
Yeah, I can see them.
Okay, so this is our case today. We have a 64 years old female with abdominal distension for 10 months. To you, Joseph.
Yeah. Thank you. Um so first of all, thank you again for taking your time and preparing the case for everyone to learn from you. And so this is elderly female with abdominal distension for quite some time. 10 months is it's a long time for a complaint like this. So an abdomen in usual ways shouldn't be distended. So if it is distended, it means there are stuffs that are filling in the abdomen that in in a normal anatomy and normal physiology shouldn't be there, or they are there, but their sizes and have now increased from the normal that are used to be. So if an abdomen is distended, you ask what are those things that are filling this abdomen to such an extent that we are seeing it as distended. A lot of things are there, but to mention a few, one most common that we see is water. So we're talking about ascites here. But another liquid stuff can fill the abdomen, and I think there's no need to go into there. Another thing, they can be solids. So any solid can fill the abdomen. Either it's a mass that is the abdomen is not its usual site, or it's just abdominal viscous that have enlarged in size. We're talking about things like splenomegaly or hepatomegaly or hepatosplenomegaly that can fill the abdomen. 10 months is something which is not acute. So you cannot be thinking like things that can fill the abdomen to happen acutely, like maybe intestinal obstruction. So that is not the case here. So having said that, I think we can hear how the story unfolds and see what is this that is filling in the abdomen. And if we know what could this be, we can go down that framework to so that to help this woman with the diagnosis. Thank you.
Okay. Thank you, Joseph. So, just to recap, you said it could be fluid. What else?
Solids.
Fluid, solid. What else?
Yeah, maybe if you go to that fetus can is not possible here 64 years old, but fat is possible. Again, fat maybe it is not a wouldn't be a complaint here.
Okay. Thank you. So, uh, it's already getting interesting. I hope you've already hit that button.
Yeah.
Yeah, we proceed. So on the HPI, I think this will be a short case today. So the abdominal distension was of gradual onset. It was slowly progressive. There are no aggravating or relieving factors. Initially, it wasn't associated with any symptoms, but a month ago, that is 2 months after the initial presentation, I mean 9 months, she started presenting with dyspnea on exertion as well as dyspnea on lying supine, but it disappeared when she lies on the side. She denied a history of waking up at night due to air hunger, palpitations, or chest pain. There was no history of lower limb or facial swelling, no reduced urine output, no frothy urine or blood in urine. She reports normal bowel movements, no abdominal pain, no nausea or vomiting, no yellowish discoloration of eyes, no vomiting blood or black stools. There is no fever, no night sweats, but she endorses mild weight loss. She also denies PV bleeding or abdominal PV or abnormal PV discharge. So that's it about the HPI.
Yeah, thank you. So this is the abdominal pain that has been going on for 9 months, and then it's just in the last months we are seeing other symptoms trickling in, and these are SOB on exertion and difficulty breathing on lying flat. So if you hear these symptoms quickly, as usual, you should run to the heart. But you realize maybe this is not the case here. This woman was sitting with this distended abdomen, which is increasing size for 9 months. And then it's just in the last month that she's coming in. To me, that translates to the fact that the abdominal distension, whatever that is inside there, I believe should be water now, because 9 months and then in the past 1 month you are having pressure symptoms. So maybe the distension is too large so that it is compromising the respiratory system by compressing the diaphragm, making it hard to exert. And then if you lie flat again, if you lie supine, it's easier for the fluid to the fluid get access easier to the diaphragm compared if you lie on one side, because if this is water, which I believe it is, it goes one side and then half of your diaphragm remains free. Another thing that I saw there is that I said this patient is presenting as with a weight loss. So weight loss should be taken very very serious in a patient like this, because she's having new stuff in the abdomen, which you expect she should be gaining weight, but at the same time she's losing weight. So the weight loss here, even if it was 1 kg, even if this patient wasn't losing weight, but she remained on her usual weight, you should be worried, because you are increasing stuff in your abdomen, and then your weight is not increasing. So it means some things else are going on. If you approach a patient with weight loss, if you want to be practical, you just do like two, three things. You order blood glucose, because patient with overt diabetes lose weight. You order HIV in this region, patient with HIV/AIDS lose weight, and then you screen for what we call age-specific malignancies. For example, I am in my early to mid 30s. You will screen me. Maybe I have testicular cancers. In this woman, 64, anything is possible, but other things can increase her risks, including maybe if she's smoking, you go and screen the lung cancer. But that is if you want to be practical. But if you realize this is not the case, so you lie back and think of weight loss. So is this woman not taking in nutrients? That's why she's losing weight. Or else she's taking nutrients, but it is not properly absorbed. That's why she's losing weight. Or the nutrients is getting absorbed, everything is going well, but she has something which has increased her metabolic rate. Things like chronic infections, things like malignancies, things like autoimmune diseases. These things, they increase your metabolic rate and you're consuming a lot of energy more than you're ingesting in. So I'll be there in thinking about weight loss and abdominal distension in this patient. We are told here some things that. Can you go back to the last slide, David? I saw some important negatives. No. Yeah. Okay. Yeah. So we're told that there is no lower limb or fascial swelling, no reduced urine output, no frothy urine. So reduced urine output is not that important because we will have a creatinine at the end. I cannot sit on this and say, oh, there is no chronic kidney disease in this patient. Frothy urine is trying to tell you that her urine has no protein, but again, it's not such reliable. And of importance, lower limb and fascial swelling. So fascial swelling happens in patients who will be losing protein, for example, and lower limb swelling with abdominal distension. When we see those two, we immediately go into thinking the hydrostatic pressure of this particular patient is going up, fluid is being pushed out, and then it is filling in the abdomen and then into the tissues of the lower limbs. So if there is no lower limb or fascial swelling, they're not telling me that this is impossible to be increased hydrostatic pressure, but they are reducing their possibilities. And I'm just sitting here and thinking, okay, if this will turn out to be ascites, which I think it is not from hydrostatic pressure, and it is from something else. We're talking about maybe an inflamed peritoneum which leaks into the peritoneal cavity. Yeah, so we should go on here, and I see other stuff.
Okay, so that was the HPI. We go to review of systems. Nothing significant. So CNS, there was no confusion, no loss of consciousness, or change in sleep pattern, personality change. On integumentary system, there is no rash, skin hardening, color change, hair loss or nail changes. And on musculoskeletal system, there is no joint pain or swelling, no muscle pain. In the past medical history, she has a history of hypertension. There is no history of blood transfusion, no history of vaccination against hepatitis B virus. On medications, she's on losartan H and amlodipine, no other medications. And on the family social history, she lives with her husband in Morogoro, Kilosa to be specific. She's a farmer involved in rice, maize, as well as beans cultivation. She's a lifetime non-smoker, does not drink, no history of intravenous drug use. She denies history of multiple sexual partners, and there is no family history of chronic illnesses. Yeah, so those are the other components of history.
No, thank you. So um, that's a nice history, especially asking of status of hepatitis B vaccination. So we all know that hepatitis B vaccination, if you're not vaccinated, you'll be in risk of acquiring chronic hepatitis B infection, which will put you into risk of progressing into cirrhosis or HCC. And the two can present with abdominal distension. But we will test to see whether she's infected or not. But again, that doesn't give me the flavor that this case will turn out to be in that way, because hepatitis B, as I said, it keeps you in a risk of getting a cirrhosis and or a HCC. These are very aggressive diseases, and their survival is not that great. So for someone to live with a decompensated cirrhosis, maybe now we are talking about 10 months. She was home, she's coming in for the 1 month because of pressure symptoms. I don't think if we go into there. Of another importance is the epidemiology of these patients coming from Ogoro and involving herself into rice cultivation, meaning that she is also in risk of getting schistosomiasis, which can also present with periportal fibrosis, which can also complicate into ascites and present like this. So that was a particular important history. Hepatitis C, we are told, is negative. There is no risk that IVDU, especially in this area. And yeah, I think we should proceed.
Okay, so in general exam, the patient was fully conscious. She was febrile. I forgot to edit this one, so she's pale actually. She's not jaundiced. There is no lower limb edema, no palpable peripheral lymph nodes. She did not have any stigmata of chronic liver disease. The vitals were within normal limits except for the blood pressure. She had a systolic hypertension, and the pulse rate was 103. So that's the general exam and vitals. Coming to abdominal exam, she had generalized distension. It was moving with respiration. The umbilicus was centrally located and inverted. She had no visible superficial veins, no surgical traditional marks. The abdomen was non-tender. The liver, spleen, and kidneys were not palpated. Fluid thrill was positive. Liver span was estimated to be around 13 centimeters by scratch test. Bowel sounds were heard. Digital rectal exam was normal. Other physical exam, cardiovascular exam, except for the blood pressure, was normal. Respiratory exam was normal. Neurological exam was also normal. So that's physical exam. Back to you, Joseph.
Yeah, can we go back to the general?
Okay, on general exam, here is the general exam.
Yeah. So she's pale, yeah?
Yes, she's pale.
Okay. Yeah, very nice. So I think I can discuss this pallor. So pallor translates into anemia. And do I have an approach to anemia? Yes, I do. You have anemia because of three causes that I think we usually study when we're in medical school. Either your marrow is not making up enough RBC, or maybe it is making enough RBC, but they are destroyed peripherally, and maybe lastly, yeah, you are not making, or it's they are destroyed peripherally, or you are losing. So Can I connect anything here to say that the mother of this patient is not making enough RBC? I think it's too early, and then it will be difficult, but I don't see that coming. Another thing, are they destroyed peripherally? There is nothing like that here, and we are not told that this patient is losing blood, because we're not told maybe she has had like black and tarry stool, which is melena, that she's losing blood. Another thing that can be there is chronic illnesses can also cause anemia, but that should be a diagnosis of exclusion after we have ruled out all other things, and we'll do that when we get the labs later. No peripheral lymph nodes. This is very good, but again, it doesn't tell whether it's truly there is no. These are the ones that we can palpate, but there are lymph nodes that we cannot see. We need imaging from inside, and there is no stigmata of chronic liver disease. This is of particular importance here. So maybe we are not dealing with a chronic liver disease, but ascites of other cause. Can we go to the abdominal exam? The next slide. Yeah. Okay. Okay. Yeah. So what I see here is that this is massive ascites, and I believe this is what explains the presentation of this patient. And I believe the presentation was from pressure symptoms: too much ascites, compressing the diaphragm, patient presenting with a SOB, and a difficult in lying flat. So now, if you know what is filling in the abdomen, it's so easy for you to go down to a particular framework. And my framework of ascites, it is so practical, because when we think of ascites, what we do is we take that ascites and send to the lab. What we want to be told from the lab is this a transudent or an exudate, by doing the SAG. We'll see later if it is there. But I use this to frame my differential diagnosis to any kind of ascites, and it has never failed me. So let's say it will, if it turns out to be with a SAG of more than 1.1, which will be a transudate, we put the differential diagnosis of a transudent in ascites into two groups, because what it will reflect is that this is a portal hypertension. So it is either a cirrhotic portal hypertension or a non-cirrhotic portal hypertension. We have seen, and David has told us, there are no stigmata of chronic liver disease. So probably we're not dealing with a cirrhosis here. But how about a non-cirrhotic portal hypertension? In this group, we have things. So one, as we, and of particular importance to this patient, as we have told, she's working in, she's cultivating rice in Morogoro. So periportal fibrosis from intestinal schistosomiasis is one will give you a non-cirrhotic portal hypertension. But again, there are other things that can cause portal hypertension, and this include maybe you have a blocked vessel that will transmit pressure downward to the liver, and the liver will sweat and pour water into the into the abdominal cavity. So we are talking about things like if maybe a portal vein thrombus. I don't think so if that can do that, and it doesn't even go with this, because that presents with a pain. But there is something. There is another thrombus that I think sits in the hepatic vein. A thrombus sitting in the hepatic vein, transmitting pressure to the liver, and then you have again portal hypertension. Yes, the name is Bad Chiari, I believe. Yeah, Bad Chiari. So if you have that, also can cause non-cirrhotic portal hypertension. And maybe there are other causes that I forget right now. But on the other hand, if it will turn out that we are having a SAG of below 1.1, meaning that this is a transudate, that has its own differential diagnosis there. But what it will mean basically is that the peritoneum is inflamed, and being inflamed, it is pouring fluid into the cavity. So we can have chronic infections, peritoneal TB in this region, very important. And do we have other infections that I know that can do that? I don't think so. I don't think so. But other things that can cause inflammation of the peritoneum, and then it pours fluid into the cavity, include autoimmune diseases. And here I've seen patients with a SLE presenting as ascites as one of the features. But I would say there is nothing in this case that is going to that direction, telling me maybe can be a particular autoimmune infection, autoimmune disease. Lastly is malignancies. So, so maybe peritoneal carcinomatosis from mets from anywhere. It can present like that. But lastly, patients with ovarian tumor, they can present with ascites, and it can be into what we call a Meigs syndrome. I think they have a fusion, they have ascites, and then they have an ovarian tumor. So yeah, so if it will turn out to be an exudate, I'll go into that direction. So we can hear more from you, David, and see.
Thank you, Joseph. So we proceed to the next part. We proceed with the investigations, because that's where we are going. You can summarize for those who have joined while we were discussing.
Yeah, so David has been presenting a case of a 64-year-old female with a past medical history of hypertension, who is presenting with slowly progressive abdominal distension, with no stigmatas of chronic liver disease, and the abdominal distension is non-painful. There is no lower limb swelling or fascial swelling. And on exam, all we saw was she was pale, and again, the abdominal exam was positive for massive ascites.
Thank you. So we proceed to the next part, which is the labs, and this one is also short. So here are the labs. On a CBC, I hope you can follow, Joseph.
Yes.
So I did not highlight any, but this is almost all the labs that we have, except a few. So the CBC, we have a WBC count of 8.6, and in differentials, neutrophils 6, lymphocytes 1.9, monocytes 0.5, eosinophils 0.06. The RBC count was 3.5, HB 7.1 with an MCV of 69.3, MCH 20.1, MCHC 29, RDW red cell distribution with 15.2, and platelet count 508. And the liver enzymes are seen there: ALT7, AST16, albumin was 34, PT, PTT, and INR are normal, creatinine 143, urea 6.7, sodium 144, chloride 103, potassium 3.1. Serology is hepatitis B surface antigen, C virus antibodies, as well as HIV were all negative. Okay, so you can discuss that one.
So, if I summarize this lab, is that the CBC is remarkable for a moderate anemia with thrombocytosis, right?
Yes, right.
And again, MCV is microcytic. The creatinine is elevated, right?
One is elevated,
This albumin is normal.
just slightly low because the lower limit is 35.
35, yeah. So,
Yes,
so creatinine elevated, and what other thing? The potassium is mild hyponatremia. Eh?
yes, right.
Yeah. So this is the good lab to discuss. So let's start with the CBC. Here we have this patient was pale, and we are told here they have a microcytic anemia, which we expected. So what is the differential diagnosis of microcytic anemia? If I can recall well, we had a mnemonic called TAILS. Yes, TAILS. And the T stand for thalassemia, very common around here. A stand for, no, I forgot the A. I'll remember it later. But I is iron deficiency anemia. Yeah, the A is for anemia of chronic illness. So T for thalassemia, A for anemia of chronic illness, I for iron deficiency anemia, L for lead poisoning, and S is for sideroblastic anemia. So the two can be the cause of this anemia of chronic illness or iron deficiency anemia. Iron deficiency anemia, maybe this woman is losing blood slowly from the guts, or anemia of chronic illness is, but as I said, anemia of chronic illness, this is the diagnosis of exclusion. You have to keep it at the back until you realize there are no other things that can explain this anemia in a patient with a chronic illness. This platelet of 508, it can't go without being discussed. So we know the causes of low platelets, but how about high platelets? Because this is high. The cutoff in our labs is either 400 or 450, and this is for 500. So as you think of any rise in a blood cell line, if it is rising, you think one, there is a clonal multiplication, or two, it is reacting to something in the periphery. So clonal multiplication of platelet, we're talking about something like maybe essential thrombocythemia, which I don't think if that we have that flavor here. I don't think if you have that flavor because it won't explain a lot of things. So I believe this is from it is reacting from something. And if you are told to mention the markers of inflammation of a patient, we all know about ESR and CRP, but there are other things. One of importance is a high platelet, which we call reactive thrombocytosis. So a high platelet is also a marker of inflammation. And another marker of inflammation is a low albumin. So we are also seeing here low albumin. There are other markers of inflammation, which will include high WBC, high LDH, all those. So I can group these two platelets, high platelets, slightly low albumin, and say these can be the markers of that this patient is inflamed. And we also saw she's losing weight, so it goes into that direction. Another important thing that I should discuss here is yeah. So the patient has also has elevated creatinine, And when you see elevated creatinine, you think of a renal disease. You say, is it acute or chronic? In a patient that you're not given baseline within the past 3 months, you cannot tell easily. But working in a hospital, myself, when I see that, I assume it's acute first. I assume it's acute, and there are importance of doing that, because if it is chronic, yeah, then what? But there are things that can tell you, can try to suggest whether you're dealing with acute or chronic renal disease of high importance. And I think David have a slide here. It will be a KUB ultrasound, which will see a shrunken kidneys or a loss of or CMD loss. But again, there are causes of CKD that will not have those. But anemia with creatinine high, it's okay also to think, okay, this is CKD and this is anemia of CKD. Yeah, anemia of CKD should be normocytic anemia, but in Tanzania, as I was told by nephrology fellows when I was a resident, that cannot be the case. These people can have iron deficiency, and then they have CKD, and they can present with anemia of CKD, which is microcytic anemia. So I'll keep this. But again, if it turns out this is acute kidney disease, I would love to see the urine. I would love to see the urine and see what is happening. Does the nephrons of these patients allowing protein and blood to pass, or what is happening? And I also realize this is a patient who is hypertensive. She's on medications. I saw there, I think it is Losartan H or something. So yeah, it again keeps you, maybe it's a CKD. She has risk factors and also all sort of other things. So in conclusion, uh, we have uh, we have markers of inflammation, reactive thrombocytosis, and slight hypoalbuminemia. We have a microcytic anemia, which I can attribute probably she's losing blood in somewhere. And if we send iron studies, we can tell what is happening. Or it's anemia of chronic illness. Let's proceed. Sorry, David. Sorry, David. Yeah, potassium. It's not good to live without discussing potassium. So, hypokalemia. Usually, my experience is I will sit in the morning report in a hospital. They will say someone will come with mild hypokalemia like this. And then when we control again, it is not there. They have corrected it. So I agree with them that you correct it. But if it keeps recurring, you can try and think, where is the potassium going? Or if it is severe, if this potassium was 2, I should sit and use my brain to think, where is the potassium going? And the potassium, there are few places that it can go. One, we know it's so difficult for one not to consume enough potassium, because even a single banana, it is said it is having like 10 to 12 mil equivalent of potassium. So it's so difficult. Our foods have a lot of potassium. It's so difficult for you to not have enough potassium by not consuming potassium. So if someone has hypokalemia, they are losing it. And there are 3 ways that a person can lose potassium. One is the GI, by vomiting or diarrhea. 2 is by transcellular shift. You all know, if you want to give someone insulin, what you do, you check the potassium first. So this patient is not on those medication. And again, another medication is salbutamol, which also causes transcellular shift. Another area that you can lose potassium is the kidneys. That is a vast differential diagnosis. And if it happened later, I have to discuss that. I will go into that. But for now, I think it would be a waste of time, and let's proceed. Yeah, David, you're muted. David? David, you're muted, David. Something. Hello? Niko kwenye Zoom ndio nakupigia.
Hello, Joseph.
Yeah. David.
Yes, I disappeared. I had a technical issue on this side.
No problem.
Okay, I'm not sure where. So you were discussing
Hypokalemia.
hypokalemia. I'm not sure where you ended.
Yeah, so
Yes.
yeah, I finished discussing it and I said this, if you have hypokalemia, just correct it. But if it is, especially mild hypokalemia, if it keeps reappearing, you should take your time and think about it. Or if it is severe. And the causes are not many. So you are either losing potassium through the GI, vomiting, diarrhea, or transcellular shift by using medications like insulin or salbutamol. And lastly, you are losing potassium through the kidney. There are so many causes there, and I will see whether I have to go into that route or not. But for now, I think we can proceed.
Okay. So I should say this is an incomplete case, but then this is where you commit, or at least list a few things that you think are most likely in this patient,
No.
and then I'll present. I think the last two slides, which I do not think are diagnostic, but at least they are telling us what is going on.
Okay.
So maybe possibilities that you are thinking about.
Yeah. Very nice. So I highly doubt if this is a portal hypertension because that's a cross line. It's either portal hypertension or not. I highly doubt if this is a portal hypertension. Why? One, if you have portal hypertension, for sure there is no reason why we are not seeing lower limb swelling. But two, the platelets, if you have portal hypertension, the platelets is among the things which have a very high likelihood ratio in patients with portal hypertension. If you ever work in a hospital and you see patient with a cirrhosis or whatever cause of portal hypertension, just look at their platelets. I have always seen them low, always like 100, 70 something, 60 something. So I highly doubt if this is portal hypertension. And what we are seeing is here is thrombocytosis kabisa, the platelets are high. So if we are not dealing with the portal hypertension, then we are dealing with ascites from a, 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 an exudative cause, which means an inflamed peritoneum. Because we live in Tanzania, one thing that can inflame the peritoneum is TB. So TB peritonitis should be high there. And what others increase that likelihood? Um, One is the inflammatory markers that we are seeing, the low albumin, the high, um, the high platelets, and two, patient is retaining a lot of ascitic fluid, but still they're losing weight. You can think maybe it's kidney disease that is driving all this, but again, it doesn't make sense at all because patient with kidney disease, 10 months, and they always again gain weight unless there is something else. So I don't think I haven't plugged that number to see if we believe this is a chronic kidney disease, to see what stage is this. But I don't think if it will go into 4-5, which should be causing fluid overload. So I think this is an inflamed peritoneum. Chronic infection, TB, I put it number one there. I don't think there's a possibility of here being autoimmune disease. I'm talking about SLE. I have not seen anything else about SLE. Or, yes, we don't have imaging, but still, I don't see anything that I suggested. Also, there is a serositis from other areas like the lungs. And SLE for 10 months. It's unfortunate we don't have a analysis, but it would have been telling us something. But we don't hear joint pain, we don't hear rashes, we don't hear alopecia. So I doubt that. Malignancy, yeah, we haven't palpated any palpable lymph nodes, but it doesn't mean there is no lymph node elsewhere. So if you have malignancy with ascites like this, you're talking about peritoneal carcinomatosis. That is so late stage of a cancer. 10 months, asymptomatic, and the symptoms that brought the patient is because it's too much ascites. I doubt, but yes, she needs imaging. She needs imaging, especially also being a female, imaging of the pelvis to see whether we're also dealing with an ovarian mass. But yeah, still, I'll put peritoneal TB up there. I'll send the tests and see what is happening. I know it is difficult to diagnose, but if I have ruled out other things, what else should I do? I think I'm there, David.
Okay, thank you, Joseph. I think that's been very good teaching today. I think a lot of your discussion was very loaded, right from the history, the physical exam, your interpretation of labs. I think people had a lot to learn. So I'll proceed. As I said, I do not think this is a complete case, but we have a huge likelihood. We are thinking, so from the last two slides that I'm going to present, what are the possibilities? So it's unfortunate. I wasn't involved in the care of this patient, but then I happened to see this patient because one doctor did the examination on this patient. So I was examining a candidate, and they had this patient, and then I got interested. Abdominal distension. People were not exactly sure what is going on, but then was the patient was not very systematically investigated, because as you've seen, I have not presented any acidic fluid analysis, cytology, or anything. It was not done.
No.
But then when I went through the patient's file, the patient's labs in the system, I found some interesting things, and then I thought this could be a good learning case.
Yeah.
So, for whatever reasons, this patient, they did some tumor markers on this patient, and AFP was within normal limits, carcinoembryonic antigen within normal limits. but then CA125 was highly elevated and CA19.9. But then I thought I should discuss a little bit about tumor markers. So when we discuss learning points, I'll talk about this. And then imaging was done. So this was a contrasted abdominal pelvic CT scan, and it revealed bilateral complex ovarian cystic lesions with thick walls and enhancing mural nodules. So the largest was very huge, 16 by 15 by 12 centimeters. Significant ascites was seen, and then multiple enhancing intraperitoneal nodules. The largest located near the perisplenic area, measuring 7.5 by 6.3 centimeters. The liver was of normal size, shape, and density. Vascular structures were normal. The spleen also appeared normal, and all other things that I did not report here were reported normal. So there was no paraortic lymph nodes which were seen. The uterus was reported to be compressed and not clearly visualized, I think because of the large masses, otherwise nothing else. So the impression was ovarian cyst adenocarcinoma, and the intraperitoneal nodules were interpreted to be suggestive of peritoneal carcinomatosis. Yeah, so I thought that I should just discuss briefly about evaluation of ascites, because I believe for differentials you've talked about most of them, and then the issue of tumor markers, and then we'll come back to reflections from you, Joseph. So I took this from Up to Date. This is this table here is this is data, as I said. This is as you can see. Tuberculosis seems to be a loss of ascites in our setting. Maybe so for evaluation of ascites, Joseph, you talked about some things, and if this was done, I believe it would have been easier. And the discussion been more lively if we had acidic fluid analysis. I believe you would take us through it, and we would learn a lot from you. But then there's a number of things to be done. So gross appearance, I'm not going to touch on that. But then cell count is very important. So that is one of the branching points. But I think what I'll emphasize more on is the SAG, the serum ascites albumin gradient. So if with the SAG, so for this particular patient, we believe the SAG will be less than 1.1, which means this is an exudate, because there is inflammation going on in the peritoneum. So the acidic fluid albumin will be high, and therefore, if the acidic fluid albumin is high, which means this is an exudate. Here are some of the causes. You are talking about peritoneal carcinomatosis as one, but another one is tuberculous peritonitis, which were two differentials which were high on the list for Joseph. So Joseph put tuberculous peritonitis high on the list. I would do the same, but then you also discussed the possibility of peritoneal carcinomatosis, and we see those are the ones which are highlighted here. If you have an acidic, a serum acidic fluid albumin gradient of less than 1.1, so that would be our pathway to evaluating ascites. So for the rest, I believe we can go and and read for ourselves. But that's what we have so far. Peritoneal carcinomatosis, that means the SAG would probably be less than 1.1, and the possibilities are the ones that Joseph highlighted. I needed to talk about is about tumor markers. So tumor markers were done in this patient, but then I think we should be careful. Of course, for this one, maybe they helped us learn somewhere. But then tumor markers, when I was doing some reading for different kinds of cancers, tumor markers lack sufficient sensitivity as well as specificity to be used solely for screening or diagnosis of cancer. Except because when we talk about the role of markers, it can be in diagnosis, in prognosis, as well as follow-up. So when you talk of prognosis and follow-up, tumor markers are very useful. But then when you talk about screening or diagnosis, uh, especially for many kinds of cancers, they are not very useful because of limited sensitivity and specificity. Except in a few, when you are managing some few kinds of cancers, for example, you're talking about breast cancer, you need to know about the receptor status. They are useful there, but then for screening or diagnosis, they are limited. So I took two examples, CA125, in one meta-analysis which pulled a number of studies looking at the diagnostic utility of CA125. The sensitivity was 78%, sensitivity, I mean specificity also 78%. And they can be elevated in many non-malignant conditions, some of which I have uh, taken a slide here again from up to date. So as you can see, CA125 can be elevated in endometrial as well as ovarian cancers, but then it can also be elevated in benign conditions like adenomyosis, endometriosis, Meigs syndrome. It has also been shown to be higher during menstruation. It can be elevated in PID, but then you also have other conditions which are non-gynecologic, like ascites itself, cirrhosis, pericardial disease, SLE, tuberculous peritonitis, which was part of our differentials. So having a patient with ascites and then elevated CA125 wouldn't automatically tell you that we're dealing with a pelvic malignancy like ovarian cancer. So we have to be careful with that. And then I took another example, which is carcinoembryonic antigen. So this one is used most commonly for colorectal cancers. Again, a meta-analysis which pulled about 77 studies uh, concluded that the sensitivity was about 46%. And in brackets, there are confidence intervals. So in many of these studies, the sensitivity was ranging between 45 and 47. Specificity about 89%. And then you also have many non-cancer related causes of elevated CEA like gastritis, PUD, diverticulitis, COPD, and this applies to carcinoembryonic antigen. It also applies to CA125, that you can have patients who are smokers, they do not have any malignancy, but then if you test, you find elevated levels of these tumor markers, but these patients do not have any malignancy. So I think the take home is that they are very limited when it comes to screening or diagnosis of malignancies, and therefore we should not just rely on them in order to make a diagnosis or to screen for malignancy. And their sensitivity is very disappointing for early malignancies. So you find them elevated and the patient is having a malignancy, it's most likely it's an advanced stage of a malignancy. But then, as I said earlier, they have a role in prognosis as well as follow-up of patients who are already diagnosed with the malignancy. So those are the teaching points that I had for today. Joseph, welcome for any reflections.
Yeah, thank you very much for the case. It was an interesting case because it had a number of problems that we see usually in hospitals. So I believe everyone here heard me discussing them. And I believe when if you are listening, if you hear they have presented problem, I believe in your head you start thinking, and then maybe you realize, oh, I don't have much differential. And then if I said three differential and you had one or two, you add one or two to your brain. So that was a very nice case for this, because we had abdominal distension, we had anemia, thrombocytosis, a lot of things that to discuss from. And yes, this case also encourages other listeners that this is an incomplete case. There's no many things, but David brought it here because it is not about the end. It's about discussing the problems which we want. And I feel sorry for the patient, because 10 months with something which can be diagnosed is just a CT. It's so unfortunate in this region. So again, the teaching points, David, I think that is very, very important. You know, I sit in clinics sometimes, and patients come to me. Uh, someone ordered these things you're saying here, CEA and stuff, and then they're high. So they've been told there is a likelihood this and this. Come and see a specialist. Now they come there, and then you are sitting there. So yeah, you order something that you can interpret and in the right context, as David rightly said. So what I find important in these tumor markers is maybe CA 199 for sick pancreatic cancer. But yeah, again, the FDA, they're saying these are not for diagnosis; these are for follow-up patient with cancers. So the teaching point of David is that even if these tumor markers were normal, this patient need an imaging, and the diagnosis could be the same. So thank you very much.
Thank you very much, Joseph. And I should say I was here taking notes from the things that you were discussing. I learned a lot from your approach today. So I'll just highlight a few things, especially for the ones who are late. Uh, I do not, I think at the beginning, because I was presenting and I admitting participants, I think I missed a few things. But then a simplified approach is someone is coming with abdominal distension. So this could be fluid, it could be something solid, and I'm not sure if that was separate or not, but then it could be an enlarged abdominal viscous. And then for fluid, that could be, I mean, you have a number of things that you can think about there. That could be, it can be blood, it can be lymph sometimes.
Hmm.
Yes, it can be serous fluid. And then I was also, I also learned a lot from you in that you were not distracted by the dyspnea, because you hear someone is having abdominal distension and then they have dyspnea on exertion and on lying supine. So maybe that could distract someone and think this is possibly heart failure. But then the presentation, so when this patient lies on the side, the dyspnea disappears. So it was basically pressure symptoms from the massive ascites. And then the approach to weight loss, that if someone is having weight loss, they are probably not taking enough nutrients, or they are taking nutrients, but then they are not absorbed, or they absorbed, but this patient is having increased metabolic rate, like from an infection, a malignancy, or autoimmune disease. And then uh, when it came to ascites, classifying ascites as transudate or exudate. And for transudate, it can be cirrhotic portal hypertension or non-cirrhotic portal hypertension. And then for exudate, where the most likely diagnosis fell within peritoneal TB, autoimmune disease, as well as malignancy. Uh, Peritoneal carcinomatosis being one of them. So I think I should have just written your points of discussion and made them teaching points for this case. Very well discussed, and I think you arrived at the diagnosis. If this patient was investigated properly with CT fluid analysis, I believe uh, it would have been easier to arrive at the diagnosis rather than I think we need biopsy in order to conclude that what we are seeing is a malignancy. Although the likelihood is very high, you see complex ovarian cyst and then you see multiple nodules. But then biopsy is the gold standard here in order to make the diagnosis. So thank you very much. For these few remaining minutes, of course, we are overboard, but then I believe the floor has something to say. So for anyone who has any question, any comment, anything that you would like to share with us, you are very welcome before we close the session.
They are still reflecting.
Yes, this audience is very reflective. People are always quiet. I believe they are still processing the case quietly. But if anyone has anything before we close, you're more than welcome to share with us, because I believe Joseph needs to learn from you. I also need to learn from you. So if you have any case, I mean, anything, any experience that you'd like to share in context of this particular case, you are very welcome.
Yeah.
Okay, I do not see any hands. I do not see anyone who has unmuted in order to say anything. So thank you very much, everyone, for joining today. And thank you very much, Joseph, for discussing and teaching us. I think I personally learned a lot from your discussion. I believe everyone else had something to learn from your discussion. So again, thank you very much, everyone. So we are going to meet next weekend again for another case, and next weekend will be interesting because Sebastian will be presenting to Joseph. So
Woo.
I think that will be a different flavor. So Joseph is already excited. I believe everyone else is also excited to hear Sebastian presenting a case which he participated in, in at least making a diagnosis and being part of the managing team. So Seba will be presenting a case and Joseph will be discussing. I'll be very happy to be in the passenger seat, just learning from both of you. So welcome next weekend. Thank you everyone for joining and have a good night.
Thank you and good night.